the next talk, just keep the physics in mind. These are basic knowledge. You have to have the knowledge to compare devices and companies, and you can go for the websites as well. If you go for the ISMST website, ismst.com, or for the DGEST website, this is the German society, which has in English written as well, the DGEST, digest.-ev.com, and you can find all these physical parameters from all the companies on this website as well. Now, really more difficult. Physics are pretty easy, but now the very difficult part occurs. But within the last 2 slides, I can summarize that you should take home, that makes things much more easier to understand. This is the history how shockwaves were spread right in the world. It started in Germany, and from the urologist it comes to the orthopedist. And this is 86. This is German. This is Gerald Haupt. He's a German urologist. He's very close to Christian Chaussy. So he took over the technique to another city, and this city he has a machine where the urology department is pretty close to the orthopedic department, and Gerald Haupt is together with a very good orthopedic surgeon in the laboratories, and they have the same working place together. This is the reason why they start discussing it. And then the orthopedist that has seen the X-rays from the urologist, and he found on the treated side, if they have the kidney stone where the kidney is pretty low, and the shockwave has to pass the iliac crest, that the iliac crest on the treated side has a higher bone mass density just by X-rays. That's the reason why the first orthopedic surgeon found that maybe shockwave has an effect on bone pathology. And then Valciano, he was the first one who uses the technique, communication with the orthopedist. He did this for animal trials and treat bone pathologies at a very high energy level, and he found that he is able to produce a bone healing repair mechanism in delayed unions and a non-union model. Karl Dahmen and Markus Löw, you heard the name before, published it in the English Journal of Bone and Joint Surgery, an excellent trial, firstly describing how shockwaves can work in calcific lesions of the shoulders. The ways from the kidney stones, the bone pathologies, to calcific tendinitis of the shoulder, and then they found patients with calcific tendinitis of the shoulder have less pain, even the calcific lesion is not disappeared. So then the next orthopedic surgeons did research on how could it be, and they found that shockwave has an analgesic effect. And then they transform it to other pathologies. That's the reason why we have it right now for all these musculoskeletal disorders. Followed by all these FDA approval studies, and some of them get the approval, some of them did not. Indication for extracorporeal shockwave therapy in general, tendon, muscle, bone, skin, nerve, all these indications right now were covered by extracorporeal shockwave therapy, and I have 2 talks later on with so-called standard indications, and I give a talk on experimental new indications that you have an overlook about what's possibly applicable in the recent time we have. Shockwave devices, you know it right now, focused, radial, defocused, planar. Keep these 4 things in mind, that you have this technology, and 90% covered with the radio technology, and 10% is not covered. Then you can look for focused devices. Level of evidence, we have this evidence right now, and you can get these level and all the literature later on by me. This is a consensus statement. This is from the ISMST. This is the International Society with an annual meeting where they have a managing board. They discuss all these new indications and techniques, and we try to give recommendations and publish it on our website. And it's password free. You have an easy approach to make it, and you can download most of these things we can show here on the internet easily. The ISMST is talking about so-called standard indications or approved indication, and common a common empirically tested clinical use or expert indication or exceptional indications. And a lot of these indications cover most of the orthopedic disorders right now. You have to keep in mind, if you apply extracorporeal shockwave therapy, the treatment itself is not that difficult. It's pretty easy to apply. The most important thing is to find the right diagnosis, to look for the right patient. Not every patient who has heel pain has just a tendinopathy. This is the case, this is MRI for a patient who has a plantar heel pain. This is the calcaneum. This is the plantar fascia. And this MRI showing that it's partial rupture of the, like a tendinopathy, and you can see the rupture of the plantar fascia. The complete rupture of the plantar fascia is a very rare cases. I've seen 2 of these within the FDA trial, 2 out of 300. So mostly they have normal tendon disorders. Contraindications for all these applications, these are standard contraindication which you can find on the website as well. It has to be modified, and we are working on it because some of these contraindications are still not anymore contraindication. Some of them changed to be indications. But for example, this is a case where this is a patient with the plantar heel spur right here. Came to my office. This is one of my cases, and patient got shockwave treatment. Clinical findings pretty easy. Typical pressure pain on the medial tubercle of the calcaneum, and patient got a full cycle of treatments, retreatment with 2 weeks apart with the radio technique, and 3 months later, patient comes in my office still saying the pain is not better. I still have significant pain. I still have something like swelling on the heel pain, and then you make an X-ray. Can you see the difference between this one and this one? Do you see anyone see any differences? No difference? You should become closer. you need glasses. It's not that easy. One of my fellows, he has not seen it, for sure, because he has to look from this picture and this picture. If you see the heel spur, has anyone seen an increase of calcifications after treatment? What's the experience users? No. I'm pretty sure. There's no publication, there's no report about that. So there must be something behind. You have any idea what it is?
Cancer?
It's cancer. It's an osteosarcoma. It's an osteosarcoma. It's a female, it's 26 years old. This is a typical osteosarcoma. It has to be resected. The complete hind foot has to be resected to have a wide resection of this case. This for sure, this is just a single case. It's not a standard case. Most of you will not see any osteosarcoma in your whole life, I'm pretty sure. But in my office, I've seen many of these tumor patients, and I did the shockwave treatment in this case, pretty sure that this is plantar fasciitis, but it was not. Anyway, you see these contraindications, for sure, nerve disturbances, diabetes, reflex dystrophy, anticoagulant therapy. The patients have take some medications. You have to be aware that you can produce some bleedings and hematomas. Local steroid injection within 6 weeks. All these contraindications, they came from the FDA trials. If you download the approvals or 510A papers from the FDA, you can find a paper where all the contraindications were written down. But these are a very large range of contraindication. And recently, in my hands, I had no contraindication anymore except tumors and patients under severe coagulations. So these 2 contraindications are only 2 which I use in my office. In Canada, similar?
Yeah, so I just want to emphasize that again, contraindications. This is with the FDA study, very, very strict study, especially to get published, level 1A. So contraindications, Dr. Gerdesmeyer can also mention that actually if you're on anticoagulants, that may actually help you get better because you get more cells, more inflammation, more bleeding. And we have an MRI study that was presented a few years ago showing that if you have increased bone bruising or bleeding, it may help. And diabetes, I treat people with diabetes. Yeah. Dr. Gerdesmeyer treats. This is a very strict American contraindication. In Canada, I would suggest that you wouldn't worry about that. But cancer is a big deal, obviously. So the most important thing that Dr. Gerdesmeyer said was diagnosis is the key. So if someone's not getting better or you think there's something, look at your diagnosis again and make sure that they actually have what they, or what you think they have. Okay.
Yeah, that's right. This is pretty important. And if you have a patient which is it's a candidate for shockwave treatment and you want to do the shockwave treatment, how to make it easy, make it comfortable for you, make it comfortable for the patient, put the patient in sitting position, prone or supine position, that you have a good approach to the patient, good access to the pathology, and make it comfortable because the treatment itself is painful. You have to tell the patient when you start the treatment it could be painful, give them a couple of shots in advance that they have any idea how painful it is. And in my hands, a patient with tennis elbow, for example, they have really severe pain and they get the shockwave treatment, it's pretty hard to accept or to tolerate the energy level. This is pretty hard to make it. So make it as comfortable for the patient as you can. Localization, we've talked about that a couple of slides before. For shoulder pathologies, if you have a calcific lesion, then you need a guidance. You need a control mechanism. You can use ultrasound or even intraline X-ray system, which makes the device pretty expensive. Or you have bone pathology, then you have to use X-rays to be sure that the focus zone is the right position to treat the patient. I've used the radio technique also for small bones after hand surgery, after foot surgery. They have a delayed union or non-union. You have the fifth metatarsal osteotomy, for example. You don't need an X-ray. If you know where the pathology is and you have good anatomic knowledge, you can find the fifth metatarsal.
Look for the scar.
If you're able to find left and right, you can find the fifth metatarsal easily. So it's not that difficult as it's written down. You have seen the picture. Ultrasound imaging system is a good option. It's non-invasive. It's pretty easy to make. You have good access in most of the offices. I do it in all my shoulder pathologies to be able to find some differential diagnosis. Patients may have a severe rotator cuff lesion or rotator cuff rupture, or they have after dislocation, they have a bucket lesion or slap lesion, all this stuff. You have to look for these patients carefully. Then you can find out the right candidates for it. If you're working with ultrasound systems, something I want to say is that there is a risk of an axial deviation. There's a mismeasurement of about 1 centimeter. If you have a depth of 10 centimeters, there's a risk of too long measurements at 1 centimeter. And there's a risk for lateral deviation as well if you use ultrasound. These are some physics behind, but this is standard and good knowledge to have these guys. They use ultrasound in all the cases. Biofeedback technique, localizing technique. This is how I make it in my office. This is a patient with plantar spur pain. I'll palpate the region. The patient can guide you to the most hurting point easily. Then I make a mark on the skin with a pen or something else. Put some coupling gel on it, and then you start the treatment. And the patient immediately, within the first shots, can give you a report saying, this is a pain I have all the day when I start walking in the morning. As a cooking gel, you can use also castor oil. We found out, for sure it's much more easier, it's much more cheaper, you have all these stores that have castor oil. And castor oil has good properties for the coupling things. No cavitation bubbles, no loss of energy level, and pretty easy to make. This is also one publication showing that what happens if you use local anesthetics. This is a big issue, and we in the first decade when we have performed many prospective control trials, in many of these trials, local anesthetics were used in the active group to decrease the pain level and to make it more comfortable. And the group I was involved in this group together with Jan de Rompe from the University of Mainz. We did a study comparing groups treating shockwave with local anesthetics and without local anesthetics. And we found that the group that get local anesthetics injected to make the treatment more tolerable, they're doing not better. So the group without local anesthetic is doing better. Local anesthetic has an influence on the local so-called neuroinflammation system. If you have these kinds of pathologies and chronic tendinopathies, you have in local neuroinflammation, and the neuroinflammation is influenced and protected by local anesthetics. If you inject local anesthetics, then you cover the local neuroinflammation process, and the access for shockwave treatment to have an impact on substance P, for example, is reduced. That's the reason why the shockwave it's worth it when you use local anesthetics instead of not using local anesthetics.
And I think that's a landmark article. It changed a lot of the way that we did shockwave. When I first did shockwave in Canada, I used a general anesthetic with my patients because I didn't want to use the local anesthetic because of the effect Dr. Gerdesmeyer spoke about. And since then, we've definitely evolved into the radial shockwave, which is very effective. And in Canada, you know, it's so cold here, pain's not a big deal for us, okay? So when you're talking about how painful the tennis elbow is, it's not, with the new evolution of the machines, it's uncomfortable, I wouldn't say painful, but because of this landmark article in anesthesia, of using anesthesia, we've developed machines where you don't use anesthesia. There are still some people who have what I call older machines, they're 15 years old, that still use local anesthetic in this province and in British Columbia. And I think that that's something that it's like still driving a Studebaker as opposed to a Mercedes, Audi, what are some of my German cars? Okay, very, very important that this is not painful and you do not use local anesthetic, and that's why Storz and other companies went to this kind of model to get away from using an anesthetic. So you can imagine my first cases, I used actually general anesthetic to do the treatment.
There's a big deal behind this story because the assurance in Germany, they firstly covered all the procedures. And when the number of treatment increased dramatically, so 10 times a year, more patients were treated by shockwave treatment, the whole amount of cost was really big. And the assurance says that we want to have the evidence that shockwave for sure it's very effective or not. And then we have in Germany 3 prospective controlled trials, very large trials with all these parameters for good clinical practice guidelines with plantar Hirschberg, with lateral epicondylitis and calcified lesion of the shoulder. And both trials with the local anesthetics used in plantar fasciitis and lateral epicondylitis failed to show the efficiency of shockwave treatment. And in both trials, local anesthetics was used. And these results were completely different to all the previously published data. And we have found no reason for that. That's the reason why Jan de Grompe and we did this prospective trial to compare local anesthetics and not, because this was the only parameter we were able to find was different to all the previously published data. Applying shockwave to be aware what's behind shockwave. Be careful if you have some very large nerves, if you treat hip pathologies or you treat the medial epicondylitis, the golfer elbow, and look for the thoracic area if you treat patient with trigger point treatment and muscle insertion pathologies right at the spine. Where if you use focus devices, for example, with a deeper penetration, you can produce local damages. And in the thoracic area, you can produce pneumothorax if you have an eye energetic level with a focus device with a very deep focus zone. So keep in mind that you have the anatomy after the focus zone.
Not with radial?
Now with the radial, the question is with the radial for sure you have not, because with the radial emission of the shockwave, the energy level is lost by square with the distance. So it's pretty safe to make it. What happened right after shockwave treatment? Pain reduction for sure, mostly within the treatment. The pain tolerance is better after 1,000 shots. Initially they have very painful treatment. After 1,000 shots, the patients say that the treatment itself is more tolerable, even if you don't lose local anesthetics. And we have also soft tissue reactions. Right after we have skin regeneration, resorption of calcified lesion, bone regeneration, all this stuff. with an interval up to 4 months after treatment. Adverse events, real adverse events in my hands, none. Not a single case with severe adverse events. For sure, I have overlooked the tumor. For sure, it's an adverse event, but this is my mistake. But an adverse event performed by the treatment is close to zero, except local skin reddening, bleedings, potential bleedings, hematomas. This is probably possible, but this is part of the treatment. If you use surgery, you have to expect to have a scar afterwards. But this is not a side effect. Anyway, this is typical pictures. You see a patient when they have anticoagulant therapy, like this one below, you can have larger hematomas. If you don't have these disturbances in coagulation, you normally have only these red-colored skin after treatment. This is pretty normal. Post-procedure, as a stand, yeah.
Could you just back up 2 slides there for positive reactions after shockwave?
Okay, 2 behind. This is.
Sorry.
This is local anesthetics. Local anesthetics.
The positive reactions after shockwave.
This.
Yeah.
Okay.
Yes, sorry, just.
Okay.
Thank you.
Do you have a question? Or you just want to write it down?
I want to write it down. Sorry.
Okay.
Thank you.
But if you start to treat patient with this kind of shockwave, you can immediately see these so-called positive reactions after shockwave treatment. When to start the next shockwave cycle? This is also a clinical question. Sometimes you have patients, they still have persistent pain. A cycle of shockwave means, in my hands, you get 3 treatments, 2 weeks apart, in between the treatments, with a certain range of energy level, depends from the pathology. Then I stop the treatment because we know we have 3 months of biological reaction time. And when the reaction time is done, that means 3 months, patients still have pain and still the indication and the diagnosis is correct, then you can start the next shockwave treatment at the earliest. And in my office, I keep the patient informed about these so-called side effects, and I don't make a written informed consent, I just talk to them, and there's no assurance they make any troubles for me if I don't have the written informed consent. I just talk to the patients and explain what they have to expect. The biological effects, these so-called unwanted effects, these are also wanted effects because we want to have a better blood supply in these cases. And this is one of the early studies by Markus Meyer, published in a German language paper in 2003, and he was able to found that he can produce some bony fragments, and these bony fragments could be found in the lung, like a bony lung embolism, if he has applied shockwave with the energy level of 0.3 millijoule per square millimeters. This is far beyond the range of energy which we use clinically recently. And I'm pretty sure that no machine available on the market is able to produce these high energy levels. If you go lower, then you have never these kind of side effects that you have a loosening of any bony fragments, also if you treat bone pathologies. As a result of these so-called adverse events, we have local disruptions of soft tissues, you have necrosis of the tissues, bleedings, dislocation of bony fragments within high energetic range of treatment. And starting from 82 up to 2000, 2001, 2003, we are mostly working with high energy levels. We think about more energy means more effective, but this has changed. And you see, this is the picture from liver and the things from Markus Meyer that he is able to produce some embolism, bony embolism, if he applies very, very high energetic extracorporeal shockwave therapy. Right now, we are working with non-destroying, non-rupturing effect of extracorporeal shockwave therapy is a more stimulating effect. This is a picture from Markus Meyer. This is the bone structure, cancerous bone structure, cortical structure, and this is the high energetic structured, high energetic side effect picture with rupture of the cortical bone and the cancellous bone, we don't use these energy levels in no treatment modalities anymore. We decrease the energy level because Wolfgang Schaden, he's from Vienna, he's from Trauma Center at the University of Vienna. He's performed about 4,000 non-unions in his life. And he started also very high energetic, on a very high energy level, using very expensive devices, machines, with an anesthesiology set up. The patient get total anesthesia, general anesthesia, tolerates the treatment. And then he found that when he reduced the energy level, because he has some patients, the patient cannot accept general anesthesia, but they want to get the treatment, then he decreased the energy level, and he has a large protocol, and he analyzed all his patients, and he found that by applying lower energetic level shock waves, the results is even better. So then it changed, and we're looking for another explanation why shock wave works. And right now we have a so-called a cascade of effects. So from the mechanical impulse, we have a stimulus, we have an interaction to the cell nucleus, we have an interaction and modification of these enzymatic reactions, and proliferations and migration of certain lines of cells, which can I say later on. The working mechanism right now, and this is the key word, is mechanotransduction. Mechanotransduction means it changes the transduction from the mechanical effect to biological reaction. And there are some mechanism of and examples for mechanotransduction where acoustic energy is transferred to any kind of electrobiological pathway change. So if I talk with my voice to your ears without touching you, I can produce local electric stimulation in your brains, and all of you. So I can stimulate all of you just by talking to you, but this is by nature. This is mechanotransduction. And you can reflect the impedance, which generates the acoustic energy and electricity in your brain. You can remember my words, my voice, and all the stuff. The same pathway is used by extracorporeal shockwave therapy when the acoustic energy is producing biological reaction. This is a small film I want to show. Give me a second. This is a good picture. It's not working, it doesn't matter. This picture shows how growth vessels occur, and a very nice microscopic picture and film. This is a very difficult picture. You must not write down anything of the picture. It's too.
Quiz at the end.
So you get 20 minutes to write it down, and I'll be back in a couple of minutes. But this shows you how many of these pathways were influenced by shockwave. These are published pathways influenced by shockwave. There are many other pathways not analyzed until now, but we know that many laboratories are on the way to analyze all these changes performed by extracorporeal shockwave therapy. This is one of the key studies by Wang. Wang comes from Taiwan. He's one of the biggest basic researchers in the extracorporeal shockwave therapy, and you can read a lot of papers from him. And he did a lot of animal trials to try to answer the basic knowledge questions. And in this study, he has performed extracorporeal shockwave therapy on white rabbits and analyzed the insertion area of Achilles tendon. And he found that performing the treatment in high energetic level, repetitively done, and he did the examinations up to 12 weeks after application of shockwave, and he was able to find there is a number of so-called neo-vessels. New vessel occurs, the number of vessels and the size of the vessel increases over time up to an interval of 12 weeks. So there is a strong biological answer in this animal trial, and he published it just a couple of years ago. And he also analyzed the eNOS expression. This is a mediator for all these neuroinflammation processes. and he found that the enos signal transduction is significantly increased by performing extracorporeal shockwave therapy, and the effect lasts up to 12 weeks. That's the reason why we initiate the next cycle of extracorporeal shockwave therapies firstly at the earliest 12 weeks after the last application is done, based on these findings. And also VEGF, this is the it's a growth factor, it's a vascular endothelium growth factor. If you have a high concentration of the growth factor in your tissue, you have an increase in size, you have an increase in numbers of vessels in the treated area. Better blood perfusion, better perfusion overall after extracorporeal shockwave therapy, and the effect is also after 12 weeks after last application is done. So it's a long-lasting effect. PCNA is another modifying enzyme for these insertion pathologies. I don't want to go too deep in these biomechanicals, but you see as well that up to 12 weeks, the effect is visible and measurable in this animal study setup. In Nishida, this is 2004, and this group, this Japanese group, they perform extracorporeal therapy in a heart disease. They have did a ligation of one of the arteries, of the LCX artery, and you can see the artery is ligated right here, and they perform extracorporeal therapy, and you can see the ingrowth of new vessels coming out. This is what I want to try to show you in the film, that extracorporeal shockwave therapy produces a new vascularization. And if this is like a model for if you're a patient with a heart attack, when you have an occlusion of one of the arteries, of the coronary arteries, you have a heart attack with an ischemia afterwards. And with extracorporeal shockwave therapy, 2 groups worldwide right now working with shockwave therapy in patients with ischemic heart disease. And in this animal trial, they were able to, the Japanese group was able to show that you have a new ingrowth of vessels right after occlusion of the LCX artery. It's very initially, for sure, it's very initially, but it showed that the animal studies found by Wang et al. And other groups have confirmed it, has for sure clinical relevance. In Eichner, 2006, he found that there's also a large recruitment of stem cells. So the stem cells comes out in the treated area. They came out from the bone marrow. If you treat patient with condylitis or plantar heel pain, you have in large numbers increase and occurs in the treated area, so increase of stem cells. Is like a stem cell therapy you make. So it's a modification of your local system by the increase of numbers of stem cells in the treated area. This is from Wang. He did the same study. He's very active in this field as well. He found in the active group, the gray line on the right side, that the colonies of these stem cells is much more bigger in the treated area. Overall, this is the IMSC Newsletter. I think you can download it also from the website on the IMST. That all the factors, including VEGF, PCNA, BMP2, enos, and the growth factors, they all increase over time. There's a large biological response with regard to better blood supply and better blood perfusion. With regard to the osteogenic effects or heart tissue effects, we have also confirmed the activation of these biomechanical pathways with osteoblasts, with activation of the rest cascade, activation and production of BMP2, TGF-beta1, which is also an issue for chronic tendinopathies. So the knowledge right behind is not anymore the local destroyment, just a simple model with the Schalke stone by Markus Löw showing that we have mechanical effects, or the cortical or bone disruption by Vachanov and Haupt. It's really right now, it's very sensitive. It's a stimulating effect by extracorporeal therapy, not based on local destroyments. Endothelium progenitor cells, this is also basic knowledge. This is a keystone to the repair mechanism in chronic tendinopathies and also in ischemic areas. It's performed at the University of Frankfurt, and they found that if they can stimulate this pathway means you have an ischemic area, you have an increase of the chemoattractant factors like CDF1 and VEGF, that produces an enhanced recruitment of endothelium progenitor cells, and these progenitor cells are able to perform a healing phase, faster healing phase on this ischemic area. When extracorporeal shockwave therapy were applied, you can stimulate, accelerate these pathways significantly in many options you have in these pathways. But as a very simple slide, it shows that shockwaves have a stimulating, regenerating effect on this tissue. Stem cell therapy, endothelium progenitor cell therapy, reduction of infarction, scar reduction, improvement of function, better blood supply, activation of the chemoattractant factors, CDF1, VEGF factor. These are all stimulating effects and well known. This is a rat model, what we have done. This is a rat model where this is the abdomen, this is the head, this is the foot, and we have performed a flat right here, and this flat has an artery from this side, an artery from this side, a femoral artery for the blood supply for the skin flap, and we resected the artery right here, which leads to a necrotic area in all cases. And in the one group we did in shockwave treatment on the resected area, and you see after treatment, this group is doing well. We have no case with skin necrosis anymore. And this is severe necrosis in the necrotic area because of the weak blood supply. And the same model with the same ligation technique, shockwave therapy was done, and you see it's better outcome in comparison to a non-invasive or non-treated group. Pretty easy to see. Yes?
With all of these neogeneration techniques that you're using, are you using focused or radio shock?
Both. The rat model is performed by radio technique. We have similar models with the focus techniques. It mostly is, one study group comes out with a technique showing it's effective. Then the other companies with different techniques saying that must be the same way. It's a very competitive market because if you have one tool in your hand saying that I'm better than the others, you can believe it or not. My personal opinion is the cells have no idea which company has produced the shockwaves. So they react in a similar way. We have all these stimulating effects in all models, in all these technologies. The only thing is very important is the depth of the pathology. If you have really a depth pathology, you need higher energetic levels. Sometimes you need a focused device. Is it superficial and we have a tendency for lower energetic levels, it's in favor for the radio technique.
I don't know if you're going to mention this, but just to show the applications of what Dr. Gerdesmeyer just showed. When we're talking about a tendinopathy, do you know what the histology is? Do you know, is it an inflammation? Is it hyaline degeneration? What is, so let's take patellar tendon. What is the pathology there? When someone comes to you and has patellar tendinopathy, is it dying or is it inflammatory? Anyone? Bueller?
50% chance.
Yeah, so it's a hyaline degeneration. So it's not an inflammation. So the slides that Dr. Gerdesmeyer showed show exactly how it works on that dying tissue, so to speak, and brings it back to life using the endothelial growth factor and using those other factors from the mechanical stimulation to the cellular reaction. It then regenerates it, and every slide you show there shows you it's 3 months to do that, right? So at 3 months, you start getting that regeneration. I think that's very important, and Dr. Gerdesmeyer showed that very well, that it's the degeneration with all these factors that come to heal the tissue. So when people ask you, how does it work? Well, now you know.
So novel changes. We're looking for explanation of why you have a kind of numbness after treatment. And one of the explanations was done by Takahashi. He's also from Japan, and he found that there's an influence of the amount of CGRP concentration in the dorsal root ganglion when low energetic shockwave energy was applied. That means a desensation of the skin and the pathology. Pretty easy to explain, and it was confirmed by another group showing that we have for sure we have a reduction of the calcitonin gene-related peptides with CGRP concentration at the skin and the dorsal root ganglion. All explained. So we have a reaction of the organism to extracorporeal shockwave therapy. We have a biological activation by activation or influence on the biomechanical pathways. Energetic effects we have for sure. This is the a short summary of how shockwave works right now. Forget all these mechanical thinkings. Just keep Mechanotransduction in mind. Keep in mind that lower energy level is used. Stimulating effect is the most proven working mechanism right now, and we can use it in all these degeneration indications. That's the reason we have a fastly increasing number of indications right now. They all deal with degeneration and repair mechanism, from osteoarthritic patients, with neurologic patients, with stroke patients, and we have much more new indication right now on the market within the last 2 years. Based on these findings right now, for sure we need a large clinical trials to confirm each indication to be sure that really we are effective to treat these patients. But from a personal point of view, I think you have an options with shockwave therapy which is complete, less of side effects, without any side effects. You have many positive reactions published in all these basic research data and clinical findings. There's no time to wait. Offer it to the patient, you have no risk to make it. That's the key message.